like I said, step one is we use biometrics, just simple stuff like age, gender, race. We actually measure height. Patients lie about their height every day. They're all 2 inches taller than they think they are. And they tell you, I'm 5'8". Well, actually you're 5'4", 5'4.5". Or, so we actually measure the height and then actually measure the weight. And then we actually measure their abdominal girth. We measure their blood pressure, their heart rate, and their oxstat. We take this data, it goes on this sheet, but we also enter it into the EMR system for the practice. Because what we want to do is we want the practice's paperwork to match ours. We ask a few simple questions. If they are positive on any one of these, they have metabolic dysfunction, guaranteed. But we just ask very simple questions. If they're negative on every one of these, then this is where we stop and there's nothing else to do. So if they're overweight, their BMI is high, if they're on antidepressants, if they're at risk for addiction or opiate use, if they have joint pain, nerve pain, if they're positive on any of these, we can go on to step two. If they're negative on all
step one is if you're positive on it, that means they are metabolically what?
They're metabolically unhealthy. And that means that they have metabolic dysfunction based upon statistics of the American Diabetes Association, based upon the statistics of the American Society of Interventional Pain and the Endocrinology Society. So if we screen any of these symptoms positive, then we go on to step two. Step two is a more detailed analytics. And what it is we're screening for specific questions. The whole process takes 3.5 minutes. And these are just questions to the patient. Do you have memory changes? Are you losing your erection? Do you have frequent urinary tract infections? What this does is we're going to checkbox through this. And based upon these symptoms of checkbox, our program will generate a list that says, hey, this patient needs neurodegenerative testing. This patient is on antidepressants and should have pharmacogenomic testing. Hey, this patient's getting frequent UTIs and you should do a urine PCR because they're female. Hey, this patient is over 55, they're male and they've had a UTI. You need to do a PSA and you may need to refer them to a urologist because that's very unusual. So this algorithm tells the technician what to draw, and they talk to the doctor first before they draw anything. And they say, hey doc, is it okay to get this? The doc will either acknowledge or decline. If the doctor says, yeah, go ahead and get it, it makes sense to me, then we go ahead and draw the testing, whether that's a blood sample, a urine sample, whatever. Different panels are spun in different ways and done in we do them differently. So for example, my neurodegenerative test is something called ApoE5, and it has to be spun at a very high speed. We have to break it down, and then we take off a sample of it and we freeze it at minus 80 degrees centigrade and then send it out. So it's a very special freezer. There's other samples that are done in different ways. So our technicians are trained for that. These aren't just your regular lab techs. They're not just drawing some blood and then sending it out. This stuff is sent in a certain way to stabilize it so that we don't get bad results. And there's cross checks to all of that. Because if the sample shows up at the wrong temperature, the lab will immediately reject it because they can't run the test because it's going to be a degraded sample. So everything that we do has to have that quality control. Otherwise, we can't use the sample because we got to be able to document that we received the sample in a certain way. And so those pieces of data go in. And it's everything from looking at insulin level to looking at gamma-glutamyl transferase to homocysteine to looking at the omega-6 fatty acid ratio. How much vegetable oil does this patient have in their system? Is that what they're predominantly eating? It all depends on the patient. We get those results back, and at week 4, we do the testing, which is a combination of different testing, and these are the testing codes: 95923, 95921, 93923, and these are all the different codes. We don't do all.
So now, what was step 3 again? I got step 2, which was the screening of the questions, and then step 3 was
Step 1 was the screening and the questions. Step 2 is the drawing of the sample and sending it out and confirming it with doc to go ahead and do that. Step 3 is the actual Measura test. And this is the combination of testing based upon the results that were generated from step 2 and the review of systems generated from step 1. We have to have step 1 first, then we do the blood testing to confirm or urine testing to confirm. Then we use step 3 to create a electrodiagnostic and a reproducible metric. See, you can't repeat the genetics. You can't go back and repeat the genetics. You get it once. You can't repeat some of those tests for a certain amount of time, but the patient wants to know if they're better. You can repeat this at 4 to 6 months, and they're going to see that they're better. Their percentages change. So let's say that your percentage comes back on your ANS, pseudomotor, ABI, conglomerate testing, and it comes back at 82%. Your chance of dying is 1 in 65,000. Your percentage comes back at 60%. Your chance of dying in the next 5 years is 1 in 20,000. You come back at 33%. Your chance of dying in the next 5 years is 1 in 5. 1 in 5 people. You may not make it 5 years. So you make a lifestyle change, which we're going to give you, and then we'll retest you in 6 months, and you'll see it either going up or down, and it's dead on accurate. And we'll repeat this Measura component. Not every patient will get every test. The average reimbursement is about $450, and these are all ancillary. None of these are professional codes. These are not professional codes. They do not require the physician to do them. The physician can interpret the test, but that's an additional billable. And I'm going to go to this. So step 4 is...
Okay, so that was one of his questions, right, Lana? Because on one of those, he said, Raina, the one that said he said all of this would take, and Lana hold me accountable. Dr. Ali said, well, Raina, where you're saying that it may take 15 minutes, it's really like what I'm saying, 30 minutes. Or 3 hours.
It would take, he said it would take, he's like, there's no way you can do this under 2 or 3 hours. How? He said, you can't do it with 1 a day.
No.
So
what we have is we have an AI that combines all of the testing to be done simultaneously, and we can do all of it in 20 minutes. So we have an AI that we've developed that runs the tests simultaneously. I agree with you, the old way that it was done, it would take you 3 hours. And it would take you 3 hours to do this because the equipment was old, and each component would take you 40 minutes to an hour, and it would take you 3 hours. The actual number is 1 hour and 40 minutes. But now, because of the AI, we're able to simultaneously run it and use one piece of data to the next piece of data to the next piece of data. And so we're able to overlap the testing. And because of that, because the patient's fully wired up, when you see a patient doing this, they have literally 12 sensors on them. They've got one sensor on each arm. They've got sensors on their fingers. They've got sensors on their scalp. We're measuring EEG at the same time. And at the same time as we're having them sit and stand, it's measuring blood pressure. It's measuring EKG. It's measuring RR interval. It's interpreting that for you so that you're not having to do it manually. That's the jump in the system that we created. It's the AI. I couldn't do this 9 months ago. 9 months ago, yeah, I agree with you. This would take 1 hour and 40 minutes. Now, I can do it in 20 minutes. And you can do 3 an hour.
And so, Lana, that's what I was trying to explain to him about that. Because one of them, he said, well, first of all, the patient would have to run, and everything is time-based. I said, that's correct. I said, that's why we're going to have someone in the office just to do this portion of it. He said, well, one of them is a patient has to run for 15 minutes.
No, no, that's not true. There's different types of analytics. So, for example, we're not doing a stress echo. So that's the running.
Okay.
We're not doing that. That's not in here. We don't need to do that because we get more information from an RR interval than we do a stress echo. The stress echo is great if I'm trying to induce angina, chest pain, but even before I get to chest pain, I can figure it out with an RR interval without even stressing the heart. And then if it's positive, then I can send the patient for a non-stress test and use adenosine to do a non-stress test. And so it doesn't include those codes because it's not those codes. This is what you need before you get to those codes without putting them at that high stress level, because I can identify it in advance. And none of these codes are time-based. These are simply report-based. Now, when I get to this sheet, this is time-based, and this is step 4, and this is professional billing, and that's not included in the money that we're talking about. Page 3, step 3, we estimate an average of $450. Some patients will be $900. Some patients will be $275, but the average practice per event is $450. There are 1,100 billing there are 1,100 different ways that this can be billed based upon the patient. And so we give you the codes with the modifiers based upon the review of systems, based upon the blood testing, and based upon the result. So when we generate the report, you get the code plus the modifier plus the billing code, the DRG. And so that's different than just, you're not billing every patient exactly the same, because you're billing them based precisely on what they actually have that we've documented. And these are not time-based. Now, if you go to the next page, page 4, that is time-based. For example, health and well-being face-to-face initial assessment. It's one time a year, and it's considered a 30-minute code. The codes that we recommend you use, though, are down here. 98961, education and training for patient self-management by a qualified non-physician healthcare professional using a standardized curriculum, 2 to 4 patients, or 1 to 2 patients, 1 patient, 98960. So all of these you can bill 26 times a year. This you can bill 1 time a year. This you can bill 1 time a year. This you can bill 1 time a year. These you can bill 26 times a year. There's additional codes that you can expand your 99 codes with a G2211, and you can bill those as many times as you bill your 99 codes, your follow-up codes. So these are time element. Some of them, though, are time element without the physician, and those are the ones that we really recommend you do, because you add that to your RPM company or your CCM company. And your CCM company contacts the patient 26 times a year, and they'll spend the 15, 20 minutes. And it's separate. These codes are separate than CCM. You can still bill your CCM, you can still bill your RPM, you can still bill your RTM, but you can bill these as lifestyle coaching.